And I want to adjust so the heads aren't over my slides. Hang on. There we go. So today I'm going to present on dementia-related apathy, and the main points that I want to make are what it is and why it's important. For disclosures, I should point out to you that I've had consulting fees from the drug companies that are listed here, but the research that I'll be talking about today is all supported by peer-reviewed funding. For other disclosures, there's really nothing to talk about. Financial support, none to be disclosed. Potential bias, what I'm presenting is evidence-based, and mitigating potential bias. You know about this because you're part of ECHO, and these disclosures will be in the full slide deck. So moving to learning objectives, by the end of this presentation, learners will be able to describe the frequency of apathy in Alzheimer's disease dementia, which I'll call AD throughout, the importance of apathy in AD, and then two more recent findings, updates in the definition of apathy in Alzheimer's disease and updates on treatments for apathy in Alzheimer's disease. Just to focus you in, here are the ABCs of dementia. As this group well knows, the core diagnostic feature of Alzheimer's disease dementia is the presence of cognitive deficits. And once you move into dementia, its association with deficits in activities of daily living. Today, we're focusing on the B. Neuropsychiatric symptoms, a heterogeneous range of psychological reactions, psychiatric symptoms, and behaviors that result from the presence of dementia. It's been estimated that during the course of their illness, up to 90% of people will have one or more neuropsychiatric symptoms. So really, despite the fact that it's not a core diagnostic feature, it's certainly something that's seen clinically. So I thought that I would start with a polling question, just your opinion cross-sectionally. What percentage of persons with Alzheimer's disease dementia do you expect to have apathy? 30, 40, 50, or 60%? And this is a quick one, so we can see the results on that one. Most people said 60%, and the higher prevalences got the higher numbers. So thank you for that. And I'll show you, I guess I have to click on this to make it go in. Just that apathy, like you thought, is the most common neuropsychiatric symptom in Alzheimer's disease. In a meta-analysis of 48 studies in Alzheimer's disease, it was the most common. It was found cross-sectionally in 50%. But if you picked higher, you may have been right, because we know that from the Cache County study, for example, the 5-year prevalence estimate is 71%, and this group looked at 408 people with dementia. And one of the reasons for the variation is just that the proportion of people with apathy becomes more frequent with disease progression. And this is one of the earliest studies that showed that. Here's people with mild, moderate, and severe Alzheimer's disease. And you can see that, well, about 45% of people cross-sectionally have apathy when they have mild. This moves to over 90% by the time you have severe. So it depends what population you're looking at. For sex differences, there was a recent meta-analysis that looked at this across all the different neuropsychiatric symptoms, and they found that males and females have the same prevalence, but there's a greater severity in males compared to females. So we know the prevalence, it's the most common. Let's look at the impact. It has a big impact in both outpatients and inpatients. So starting with outpatients, we know that apathy, even once you have dementia, predicts greater cognitive and functional decline. And this is an early study by Starkstein et al. They looked at over 350 consecutive outpatients with Alzheimer's disease, and they managed to follow up 70% of them 4 years after their baseline. They found, as was found numerous times before and after, that baseline apathy is associated with faster cognitive decline based on the mini mental status examination, MMSE, and faster functional decline based on the FIM here compared to patients who do not have apathy. So that's the patient themselves. What about the caregiver? Well, apathy has been strongly correlated with caregiver burden. This is a study by Dauphineau et al. They looked at 548 memory clinic outpatients and looked at predictors of the ZBI, the Zarit Burden Inventory. And they found that as expected, cognition, MMSE, function, particularly instrumental activities of daily living, and neuropsychiatric symptoms on the NPI were big predictors of caregiver burden. But surprisingly, it was apathy on multivariate regression that was the greatest predictor of ZBI or caregiver burden amongst the other neuropsychiatric symptoms. So it wasn't agitation, which we think of often as a big predictor. It was the apathy. And we'll see from the definition of apathy later on why that might be. But first, it has an impact on outpatients, and we usually recognize that, but it also has a negative impact on inpatients. So this is a study from people in a long-term care facility. And you can see that in this study, they looked at the survival probability in months for patients in a somatic care unit on the left-hand side and in a dementia special care unit where they have dementia expertise. And they looked at 713 patients. They compared patients without apathy, who had the black line here, and patients with apathy who are the dotted line. And you can see this is mortality, that there's a huge difference in mortality. There was actually no difference between these two special care units. It wasn't statistically significant. But apathy is associated with an increased mortality in nursing home patients, a 77% increase. Each one standard deviation increase in the apathy evaluation scale score, the AES-10, is associated with a 62% increase in mortality. So it does it is associated with impacts in people in long-term care facilities as well. So for recent updates, we now have diagnostic criteria for apathy in neurocognitive disorders, so MCI and dementias like Alzheimer's disease, based on expert consensus. And these were released in 2021. They were sponsored by ISCTM, the International Society for CNS Clinical Trials and Methodology. And we also had input from the AAGP, the American Association of Geriatric Psychiatry, the NPS-PIA, which is the international group of the Alzheimer's Association US, and it's a neuropsychiatric symptom professional interest area, so people from all over the world, as well as the IPA, again, international, the International Psychogeriatric Association. And I know there are a lot of Canadians who are members of all of these groups, and we had Canadians on our panel. We got input from academia, we got input from clinicians, and importantly, we got input from regulatory stakeholders as well. So the FDA sat on this committee and helped guide how they wanted us to do these expert consensus diagnostic criteria. Because we wanted them to apply to people with neurocognitive disorders and including severe neurocognitive disorders, what makes these diagnostic criteria different from other transdiagnostic ones is that we focus on observable behaviors. So here are the diagnostic criteria for apathy and neurocognitive disorders. They can have any major or mild neurocognitive disorder, and they have to have 2 out of 3 of the characteristic symptoms, and those symptoms are shown for you here on your right-hand side. Apathy is defined as diminished goal-directed behavior, and they have to have diminished initiative, diminished interest, or diminished emotional expression. For diminished initiative, they're less likely to initiate their usual activities on their own, and they're less spontaneous or active than your usual self. For diminished interest, even if the care partner initiates some activities for them, they're less enthusiastic about their usual activities. And then finally, and this has been one of the dimensions that's been associated with the greatest caregiver burden, it's the diminished emotional expression. They're less spontaneous in their emotions. They're not happy when good things happen. They're not sad when bad things happen. They're the same all the time and fairly non-reactive. For chronology, it has to be a change from their usual behavior pre-morbidly. The duration, it has to be more or less present for the previous 4 weeks. For severity, it has to cause a clinically significant impairment in their usual functioning. And for exclusions, it's not exclusively explained by underlying psychiatric or medical illnesses. So just in your experience, I'm interested to know, what do you think is the most common dimension of apathy? Diminished interest, diminished initiative, or emotional blunting, or none? You've never seen any of those, or you've never seen anyone with apathy. All right, let's see. So we found diminished initiative first, interest second, and emotional blunting third. And everyone's seen apathy. Good to know because I'll show you on the next slide that that reflects what we saw in a recent trial. So we looked at 180 participants with apathy symptoms, and here it was defined as scoring at least 4 on the neuropsychiatric inventory apathy subscale. Even though the cutoff was 4, the mean was 7.7 in this group on the NPI apathy. And you can see that using that cutoff, almost 94% of them met the diagnostic criteria for apathy. And we saw it in the exact same order that everyone here just reported. Loss of initiative, most common. And I find we see that the most early in the disease, and then loss of interest. So it can't be overcome by initiating for them. And then the emotional blunting or the loss of emotion third. And you can see that even in the least frequent one, we saw it in at least 70% of people who met diagnostic criteria. So we know it's important for the patient and the caregiver. We can define it now. So what are the interventions for apathy and what's new in that realm? First of all, I have to tell you that we always have to talk about non-pharmacologic interventions, and they should always be done first. So I put this slide in here before talking about some of the new interventions, just to remind you that Henry Brodati did a review and found 56 studies back in 2012. And he found that exercise, music, multisensory interventions, animals, special care programming, and therapeutic activities all had some evidence, but they also commented that there was a lack of methodologic rigor and the individualized therapeutic activities had the best evidence. And then Valeria Manera in 2020 also published a review based on expert consensus, and they found that these interventions, the non-pharmacologic interventions or psychosocial interventions, had to be tailored to the person's deficits. They had to have clinical objectives. So what are you trying to solve or help with? And of course, they had to take into consideration the person with dementia's preferences. They also noted that technology in the future may help improve both treatment and delivery. Overall, there's a need for more structured research targeting apathy in particular, based on both of these reviews. So that's our non-pharmacologic intervention. So I'm just wondering, which of these medications or therapeutic groups do you think has the most evidence that they improve apathy? Cholinesterase inhibitors, memantine, disease-modifying therapies like aducanumab, methylphenidate, all of them or none of them? So 20% for cholinesterase inhibitors, 17% for all, 44% for none. So the biggest one is that nothing helps with apathy, followed by cholinesterase inhibitors. So let's look at that evidence. This was a meta-analysis done by my previous graduate student, Maya Ruthira Kuhan. She did a Cochrane collaboration one. She found 6 studies that looked at over 3,500 people on cholinesterase inhibitors. But just a reminder that the primary outcome variable for all of these studies was cognition, and apathy was a secondary outcome. So none of these studies were particularly targeting people with apathy. And they found that cholinesterase inhibitors slightly improve apathy compared to placebo. You'll notice that the mean difference is, they all use the same scale, the NPI apathy. The mean difference is less than 1 point on the NPI apathy subscale, but it is in the direction of improving. So it does have an effect, but it's very small. Next, a recent meta-analysis looking at memantine. There were 4 studies, over 1,500 people, memantine versus placebo. Memantine showed no improvement in apathy. The mean difference couldn't be closer to 0, and you can hardly see the line on here because it's right on top of the 0 line. So there does not seem to be strong evidence for memantine helping apathy, and with the same caveats from the first series of trials that they weren't targeting apathy and people with apathy, and it was a secondary outcome. And then we don't have the most relevant disease-modifying therapies in Canada will be donanemab and lecanemab, but we don't have any information on them helping with neuropsychiatric symptoms. So I'm showing you instead from the eMERGE trial, which looked at aducanumab. They looked at 1,600 people, 50 to 85. They were all amyloid positive, and they had either MCI, mild cognitive impairment, or mild Alzheimer's disease dementia. And you can see that over the 78 weeks, both groups worsened for apathy. The treatment difference did, however, favor high dose aducanumab compared to placebo, but not if you combined high dose and low dose. And again, the difference is very small, 0.32. So it may help with emergence, but both groups had the emergence of apathy. So no one's apathy got better over this trial. So I color coded them into green, yes, red, and yellow, maybe. And the other one on the list was methylphenidate. So I wanted to review for you the recent results that came out from the ADMET-2 trial that we ran, the Apathy and Dementia Methylphenidate Trial 2. It was a phase 3 randomized placebo-controlled trial of 6 months. It was the biggest run to date targeting apathy. We had 200 people who were diagnosed with apathy and Alzheimer's disease, and we randomized them to methylphenidate, 20 milligrams per day or placebo. And of note, we also considered psychosocial interventions. Both groups had a manualized psychosocial intervention continued for the whole 6 months of the trial. So what we're looking at is whether adding on a medication helps compared to psychosocial intervention alone. And methylphenidate, as you probably know, is a norepinephrine dopamine reuptake inhibitor. For norepinephrine, we know that the link with reward and motivation has been well established across diseases. And my group in particular linked the deficits in the dopaminergic system with reward and motivation problems in people with Alzheimer's disease. And for the noradrenergic system, it's been associated with memory, attention, energy levels, and regulation of emotions. So it's been hypothesized that together, the dopaminergic and noradrenergic systems are your best bets to influence the different components of goal-directed behavior. For example, motivation in the case of dopamine and energization in the case of the noradrenergic system. So that was the rationale for choosing this medication. And I just showed you, since it's a short talk, some of the brief findings. So first, ADMET found that methylphenidate was efficacious for treatment of apathy and Alzheimer's disease. The NPI apathy and CGI were our co-primary outcomes. So first, for NPI apathy, the NPI apathy score improved 1.3 points greater in the methylphenidate group compared to the placebo group. So here at baseline, they both score about 8. They both dove down. Everyone's receiving a psychosocial intervention, and here's the change score. So the Cohen's d, though, would be small to medium at most, and the number needed to treat is 8 patients to have one respond just on the basis of methylphenidate. And for CGI, which you know is a measure that's supposed to reflect clinical significance, the odds of improvement on the CGI-C was 1.9, which was not quite significant until it was adjusted in the longitudinal model. You can see that for methylphenidate, 44% of people improve and 35% of people improve on placebo, which means 56% on this measure do not. We also looked at remission, so scoring 0 on the apathy scale. You can see that this is a survival curve, but it's survival for apathy. So 100% of people have apathy at the beginning. And if the line got down to here, it would mean no one had any apathy at the end. So in this analysis for remission, for the first 100 days, the methylphenidate group had twice the increase in remitted compared to the placebo group. And after that, the lines become more parallel and less significant up to 250 days. Also well tolerated. 90% of people, regardless of group, completed the trial. There were no deaths. 17% of people in methylphenidate group had serious adverse events, and 12% in the placebo group. And in the methylphenidate group, they were considered unrelated. So that's the ADMET-2 trial. And based on ADMET-2, which of the following characteristics do you think would predict response to methylphenidate over placebo in a person with Alzheimer's disease and apathy? Male sex, the presence of NPI anxiety, the presence of NPI agitation, or being stabilized on a cholinesterase inhibitor, which we saw can have some effect. And it's more severe in males, as we saw. Stabilized on a cholinesterase inhibitor. Ah, good group, good group. And then I have to switch back to slides. Here we go. So we found 6 predictors with a larger difference in effect. There was a difference in effect of at least 2 points on the NPI apathy scale. Methylphenidate is more efficacious than placebo in people stabilized on a cholinesterase inhibitor. Also in the younger age group, which in this study was 52 to 72 years of age, people with normal diastolic blood pressure, which we think is a reflection of their underlying noradrenergic tone being in the normal range, with more functional impairment, which may reflect that with apathy, you have a decrease in your function, even though cognitively you can still complete some of these tasks. So there is room for improvement. And they should have no NPI anxiety and no NPI agitation, which we think is consistent with how methylphenidate works. Obviously, this is circular reasoning because I'm using the same predictors in the same trial. So we would have to validate this in another separate different group before those can be confirmed. I also wanted to point out the factors that weren't related: sex, education, severity of cognitive impairment, or severity of apathy. It didn't matter if you were on memantine or stabilized on a serotonin reuptake inhibitor, SSRI, and we had very few people on SNRIs, and any other neuropsychiatric symptom did not influence outcome. For the impact of predictors, overall, you saw that 66% of patients benefited if you base it on 4 or more points on the NPI apathy. If you're above the median on a score generated from the model from these 6 predictors, almost 80% of people respond, compared to being lower than the mean index score, where less than 50% of people respond. So in summary, in Alzheimer's disease, apathy is common, has a negative impact, and recently proposed diagnostic criteria have been published that define clinically significant apathy. Apathy doesn't improve significantly with the current Alzheimer's disease pharmacotherapies. It probably helps with emergence more. But apathy 2 did show that apathy can be a drug-responsive behavior, even when you have a psychosocial intervention in place. Future research, validation of the diagnostic criteria, validation of the predictors, and expanding them so that we can have personalized medicine and to monitor treatment response in subtypes of apathy, and being able to identify apathy in prodromal states and treat it. So with that, thank you very much to my lab, the collaborators for the research that are shown, and for persons with dementia and their care partners. And I did in the slide deck give you 2 bonus slides, one that both that are relevant to the case you're going to discuss, one that talks about bupropion and one that talks about features that help distinguish apathy from depression. So you can look at those later on. Thank you.